Hello, thank you so much for joining us. We are going to have such an exciting panel, and we're going to be talking about readmissions in post-acute care. And I'm assuming that you are interested in this topic. That's why you've joined us. We're doing this webinar live. And so what that means is if you have comments or questions, you can feel free to post them in the chat. They'll get fed to us in real time. The other participants in the webinar aren't going to see them, but we'll be able to see them, and then we'll be able to share them with you. I'm Brian Silverstein, Chief Population Health Officer and Innovator. I'm going to be the host for the panel. And man, we have an amazing group of panelists here, some true experts. And so this is going to be super exciting. And so we have Keith, who's the CEO for Provider Partners. In addition to his daytime duties, where he's doing a great job leading his organization, managing patients, he also is a fan of the water. So that means that you're going to find him boating, you're going to find him on the beach. Sometimes, don't tell anyone this, he might even be doing webinars from the beach. And so, is that a real background we're seeing, or one of those? We have all seen the commercials of the person with the green screen at the beach. Could be him today. Who knows? We'll see what happens with the light shadows as we go along. We also have Phyllis, who's an EVP for real-time medical systems. And so Phyllis is an avid reader and gardener, and it's pumpkin season, so she's growing some prize pumpkins right now. So in addition to readmissions, you could ask her for some gardening tips. And we have Katie also, who's a customer success manager from Real Time, and Katie's the football mom. So she was actually checking the weather, seeing whether it was going to be muddy conditions for the game or not. So lots of us to discuss, lots of us to talk about. We do want to make this as interactive as possible. And so in addition to the chat, we're also going to have some polling questions. So we're going to bring up our first polling question, and this is going to be your chance to, share and participate in the conversation. And the first polling question is, do you believe reducing 30-day readmissions is one of the top priorities for your organization right now? And so this is a yes, no. So hopefully you're going to be able to provide us with your perspective on this. If you're logging in, chances are you're going to say it is one, not to try and sway the voting any one way. Although I am from Chicago, so we do have some interesting voting practices at times. And interestingly enough, the hosts and the panelists were not allowed to vote. So we see the question, but we don't necessarily get to participate. So as we're bringing the poll questions up, we should be able to have some results soon. And once we do, we'll be able to have our commentary and discussion around them. And so hopefully we're getting some poll results. And there we go. All right. As we expected, it is predominantly yes. So we're seeing 94% of people saying this is one of the top priorities for your organization. And we got 6% of people saying, not really. And so certainly glad for you to join us, though. The 6% maybe will change your minds and you will think it's going to, or help you change the minds of those in your organization. So turn to our panelists and commentary on our poll results at 94%.
I don't think that's surprising. I think we all face those readmission challenges, whether we're a health system, an ACO, an I-SNP, any type of those value-based care programs. That is really a focus, not only from a financial perspective, which we'll talk about later, but certainly from a quality perspective and a patient experience perspective.
Absolutely.
Yeah, and I think in addition to that, and you'll hear us talk about this a little bit later, there's in the world of long-term care in particular, there's not just readmissions, but there's that initial admission that ultimately and often can be avoided through better care coordination. And so if we had added something like that into the question, you probably would have thought that that was important as well. So we kind of look at it as the both admission or readmission activity can really be a negative, and but obviously there are some admissions that are quite necessary and real. So we're not suggesting that. So thanks, Brian.
Absolutely, Keith and Phyllis, and certainly we all know this. When there is a readmission, it's going to be more costly than the initial admission too. So when you're talking about readmissions, that's going to be $15,000 more, and obviously it's bad patient care. And so to the extent that we can avoid those things from happening, it really does make a difference in people's lives. And so if we want to go to the next slide, this is certainly it's a problem for many, many reasons beyond just the notion that you have a scenario where a patient unfortunately is having to come back as an inpatient again. There also are financial issues related to this.
Yeah, and I think as we look at data that's out there from many studies, what we find is that, 70 to 80% of readmissions are preventable, which is really sad because we want to, the goal of care should be to keep people out of the hospital, keep them in their location, whether they live in a SNF or they're temporarily or are from home. So obviously, we have a lot of opportunity around that. And not only from a patient care perspective, but there's CMS penalties, a lot of uncompensated care out there, and some of that underutilized capacity as well. So really, this impacts your value-based care program. As Keith said, no matter if you're an MSSP, an ACO REACH, an iSNP, and those types of programs really focus on driving value over volume. And, it's been a shift that's been going on for us since like 2012, 2011. And while I think we've made a lot of progress, we probably haven't done everything that we can. And so, Brian, just give me some thoughts that you have seen from your provider experience and your interactions with other providers.
Absolutely. This is certainly something that when you think about typically, with these different readmissions and the impact on the margins, is that I think there's increasingly awareness when you take a closer look. Oftentimes, unfortunately, these are scenarios that if there was better information, if there was better coordination, these are things that are unfortunate misses. And not because anyone isn't trying their best or doing a good job, but we all know this. When systems get overloaded and there's so much influx coming in and so much of a burden, it's really hard to triage and say, okay, when everything's important, nothing happens. So we got to focus on the things that are more eminent. And then, unfortunately, there's something that, today this isn't necessarily, a critical thing, but as time goes on, it turns into one. And that's what results in the readmissions. And so part of this is how can we start to shift the frame and start to think about what are early indicators that perhaps if we pay more attention to that today, we're going to be able to avoid what's going to be to come.
Yeah, and Keith, I think you experienced this, as you mentioned, with not only readmissions, but admissions. And how does that affect your iSNP and ACO REACH programs that you work with?
Yeah, so in our business, we look as partners to two types of providers, and I always say that because if you're a nursing home provider and somebody uses the word provider, you think they're talking about you. If you're a PCP provider, whether an MD, a PA, or an NP, you think they're talking about you. So being agnostic with providers, we're very clear to talk about the importance of both of them, and they're both always very important in the construct of our value-based care and certainly in our iSNP. And I would say that beyond the margin thing, and ultimately a lot of things affect dollars, but the disruption, if you put yourself in the shoes of both a PCP provider and a facility provider, you find yourself these admissions or readmissions become very disruptive. There's a chance that patient is going to be case managed out of a hospital and mistakenly sent to another facility. That happens unfortunately a lot. Then that means there's disruption in care. The PCP doesn't know where they are. They normally would be their main care provider, the director of nursing and the nursing staff, expecting that patient to come back, and not to mention all the uncertainties that happen when a patient leaves the hospital after many times getting a full workup for stuff that's been very appropriately managed within the nursing home. So there's so many parts and pieces to why admissions and readmissions are disruptive beyond, the margin side.
Yeah, and it looks like we already have a great question in the chat. So I'll read that out and then ask our panelists to respond. So the first question, I've heard that CMS is starting to claw back or withhold reimbursement on entire DRGs um, uh, on that with the value-based care payment model, but also not only with value-based care, but also on fee for service. And is anybody hearing that or seeing that out in the market?
Yeah, I haven't seen. I know there's CMS penalties, and if you're a hospital, depending on where you are in the country, there those readmission penalties. Some don't even think they're that severe, so they don't overly pay attention to it. If you happen to be in a state like Maryland that has a little bit different reimbursement system, they pay a lot more attention to it because it can impact their reimbursement dramatically. But whether they are actually taking entire DRGs out of the readmissions, I wouldn't be surprised. I'm just not hearing that myself. And I think that's the whole reason that in our programs we want to have a proactive approach, so that no matter what happens, certain things will happen to a patient. Certain patients will need hospitalization for certain care, emergency care, et cetera. But oftentimes they're not. And that's the kind of stuff we're trying to focus on in value-based care and Medicare Advantage models designed for nursing homes.
Yeah, I haven't seen any clawback of DRGs either, but there certainly there are penalties. And not only on the acute care side, but on the post-acute, there is a withhold quality piece for skilled nursing facilities. And if you don't meet the quality metric, you do not have a chance to earn that money back. So we're starting to see that going more and more. There's also a second question here. How do you talk about the importance of readmission to a health system CFO who may be conflicted with value-based payment models, but also with fee for service and want admissions? And Brian, I'm going to throw that one to you for a first comment.
Absolutely, Phyllis. And and just to to piggyback on the first question, what CMS is doing that I'm sure everyone is aware is that if your readmission rates are higher, then it actually impacts all of your DRG payments. So that's what speaks very nicely then to question number two. And so, hey, if you have the CFO that's saying, hey, you know what, these VBC dollars, they're just not that big. It just doesn't, it's not moving the needle enough. I don't want to pay attention. When you start to realize that actually these programs impact all payment. And this specifically applies for readmissions. It also applies actually for physician Part B payment. And so participating in many of the Medicare quality programs and participating in the value programs can exempt you from that or provide some enhancements there. So I think the way you want to talk to the CFO about this is more understanding what are the total dollars that are at stake here, and when you add up and say, okay, depending on the size hospital system you are, if you're talking about 3% of all your Medicare Part A payment, that's going to be a pretty large dollar amount. And that's what lends itself then to be the nice conversation to say, hey, if we're losing this much money already in reduced payment, wouldn't it make sense to invest in some programs so that we can not lose as much?
Great
Yeah,
answer.
and I would add to that, Brian, that it also depends on what type of health system or even just independent hospital, because the whole goal is that all the studies and information and that has been done from real independent parties would say that the readmissions are mostly unnecessary, not all, but mostly unnecessary. So the question really for the CFO is, do I have another type of admission that we'd love to get in the hospital, and these readmissions are actually clogging up capacity? I hear that an awful lot. I've experienced that myself in my roles in the past. And so we kind of needed to kind of clean out the stuff that should be happening to accommodate the stuff and the emergencies that do need an admission. And so it really depends on their health system situation. I can see that, because I also say, just because this kind of question provokes this comment, is value-based care in the community model for Medicare programs is very different in some ways, not the construct of trying to improve care and reduce the total cost of care, but the difference of those value-based programs versus a long-term care focused value-based care program becomes super important because, like I said, in our model, and what you'll hear about later, is we're partnering with the facility and the PCP provider to really focus on their long-term care patient. Many of the patients in that nursing home will be short stay patients that are there for a 30 or so day stay for rehab or some other care, and they're going to go back to the community. So they take a different level of investment as well. And that's usually where health systems are more focused is now I have an ACO patient that's going to or needs a nursing home care. How quickly can I get them in and out of the nursing home? And so I just say that to you because there's so many parts and pieces, and you got to be really distinct and direct about which part you're talking about in terms of the arenas that you're operating in.
Yeah, totally makes sense. We can move on to the next slide. I do want to make one last comment though, as we're changing slides. The team model is coming for you, right? So team is a forced bundle, and obviously the government feels very strongly about that. So you, in effect, even if you've not been in value-based care, you are now going to be there. There's, I think, 750 or 75 hospitals across the nation that are now having to go into some sort of value-based care. So it really pays out to pay attention to those readmissions. So next slide, please.
And while we're changing slides, definitely please keep the questions coming. This is fantastic. We enjoy being able to get some of your thoughts and feedback and be able to share that. So while that next slide is coming up, then we do have another question in the chat. So maybe while we're figuring out how to get that next slide, why don't we answer that question? And so this one is to optimize a patient's physician time in a transition care management. What's our opinion on virtual transitions of care management and MedRec and different clinical levels and degree of creating a hybrid appointment?
Sure, I can start with this. So I think hybrid care is certainly appropriate. It needs not to be rushed through, whether it's in person or virtual. Really need to be able to understand what that patient went through, whether it's just whether it's a 50-year-old who um, has just come out after a routine procedure, or whether it's an 85-year-old who's going to a sniff or going home with an elderly caregiver. So I think virtually can be done. It needs to be done well, and it needs to really have the engagement of that patient.
And Phyllis, I think while we were getting the next slide up, we actually also have our next audience poll question that popped up in the effort of keeping this interactive. And so we'll go to the poll question and then we'll cover the slide. And so the poll question you have now is, in your view, which factor has the greatest influence on 30-day readmissions? And so you get to choose one, unfortunately. So this is kind of a forced choice. Option A is care coordination across care settings. Option 2 is effectiveness of discharge planning and care transitions. Option 3 is data-driven identification of high-risk patients. And option 4 is interoperability gaps limiting data flow. So everyone gets to choose, and then once we get our poll results, we'll discuss those quickly, and then we'll continue on with the program. And of course, please continue in addition to the polls. Feel free to put your questions in the chat. And so we'll leave the poll open for another moment here while everyone gets to pick 1, 2, 3, or 4. And why don't we close that poll out? Let's see what the results are, and we'll share the results with you, and then we could have a little discussion around them. So we've got an interesting mix here. So I'm going to share the results, and then I'll turn to Keith and Phyllis to give us some commentary. So the number one choice was care coordination across care settings. Number two, just one vote shy of number one, was effectiveness is discharge planning and care transitions. And then coming in third was data-driven identification of high-risk patients. And coming in last was interoperability gaps limiting data flow.
Yeah, I think I would, I'm guessing that everybody who selected an answer thought, well, this is a question where they all are important, and having the information and doing all four of these things and maybe other things that aren't listed here is super important in having an influence on 30-day readmissions. I think again, the number one and number two maybe is care coordination across care settings and effectiveness of discharge planning. I think that also depends on your perspective. Are you talking about, a patient that was hospitalized from a long-term care facility versus a patient that gets hospitalized from the community and then doesn't have effective discharge planning and care transition, and then ultimately ends up back in the hospital versus if the care coordination across care settings may or may not be more driven to that nursing home type patient. But if we had all four of the information that's listed here available, we'd certainly be able to have a lot better influence. So it's probably why we set up the question this way, because they're all important.
Yeah, Keith, I would agree. They all certainly are. One of the things that's been studied on readmissions, one of the most important things besides the four that we listed is if the patient's going back to the community to see their primary care physician within that first 3 to 5 days. And it's really about the TCM question that we just answered before, making sure the patient is clear about what the transition of care is, what are their responsibility, what are their med lists, because when you're sick in an acute care facility, you don't retain all the information that you're told there. And oftentimes discharge planning is, okay, you're going to go home, here's your packet of information, I know we talked about this, here you go, you have any questions? And just like I would be, I want to get out, I want to get home, I want to go to the next level of care. And I shake my head yes and say, that's great. And I go off and I don't really ingest all the information that I necessarily should to make that a successful care transition. So, meeting with that primary care doc is really a great intervention to prevent that, because that's the time I can ask all my questions and make sure that all my T's are crossed and I's are dotted from a patient perspective.
And I think Phyllis, you're highlighting there probably one of the key things there, which is when people are in a acute care setting, it's confusing. You're not sleeping well. Your cognition isn't there. So that notion that I want to get out is extraordinarily high. And then one of the key things too is then what are the resources then that occur after you get out? Because while you're in house, you have all these people that are around and systems and processes in place to ensure that you're taking your medications, that if you have a change in your vital signs, that there's people there to assess you. And the next thing you know, you're out. And even though it's like, oh, call this number to get your appointment, call this to do that. And it just, at times, it does become a little bit overwhelming. And so sometimes it's those simple things, back to the TCM and thinking about being able to have different virtual ones and being able to also use different types of skill levels to do that can absolutely be something that's successful. And so related to that, if we want to go to the next slide, which is talking a little bit about VBC, which we covered a little bit before, but certainly, value care delivery, which by the way is a horrible name. And so there's a slide we skipped over a couple back. And so value care delivery, a horrible name because I don't think any patient is looking really to get value in their care delivery. I think people want really good care delivery. They're not looking for value. And so that's certainly one of the challenges that we face is a nomenclature. And fundamentally, for a lot of these models, what I'd suggest is that there's a good opportunity where we're aligning financial incentives. So by saying, hey, it makes more sense to do some of these things up front that might otherwise not be paid for because you can avoid expensive things from happening later. And that really allows organizations to build the infrastructure and stresses the importance of getting the right information, the right processes in place so that you avoid a lot of the downstream issues. Now, the slide we're on right now are some of the different things that influence readmission rates, and so would love to hear some thoughts on that.
Yeah, sure. I'll make a comment here. So I think, particularly when you're transitioning not just to home and community, but to a post-acute care setting, when the handoff happens, you get maybe 3 minutes, 5 minutes of a report if you're lucky, and then you get a stack of paper. And you don't understand in those first, 2 to 3 days what the risk is for that particular patient until you start, getting in the groove and doing vital signs and, getting all their meds on board and that kind of thing. So I think that risk stratification, knowing who's at a higher risk and what's putting them at risk is really important in that next level of care. And then, as I mentioned, getting report that interoperability, getting the information you need to be able to care for that patient appropriately to meet all their needs. The way we have of getting that from system to system isn't great yet. There's still a little bit of issues in how we transfer data between disparate systems. And so that's really, I think, an issue that we see. And then, we already talked about those care transitions. So Keith, what are you seeing when your patient population makes these care transitions? What are some of the issues that your team faces in caring for this population?
Yeah, I mean, certainly having good and accurate, timely data becomes critically important. And if you have that data, it usually means your either systems are talking to each other, or at least you're accessing what you need out of those systems. You remember, there's often a PCP provider EMR. They document. Their documentation becomes critically important in value-based care for things like risk score, et cetera. They often, especially when they're moving from fee-for-service to value-based care, they're not focused on making sure they document every little thing because they simply may not have the time, and it's never been how they got paid. And now suddenly it can change in these programs quite dramatically and have a dramatic impact on the outcome of the program. But one of the things that I think companies like Innovacer do well is they're trying to create the data sources and the interoperability issues to be able to risk stratify patients. These are patients that you should be alerted on, that you should get ahead of. It's exactly what real-time system is trying to do. It's trying to use real granular data that's been documented in the facility EMR to come up with those things that either look like they are problems or could become problems. And it allows providers for the first time with taking those very rich data sources to get ahead of what ultimately is going to be what I call more expensive utilization impact. And so, and obviously the care of transition from an acute care setting to a post-acute becomes incredibly important because lots of communication is required, and it often, as Phil has said, is not really happening and it's not complete. So people are trying to sort of reincarnate what it was or what happened, what they think happened, and that's also takes a lot of time. So I think that the risk profile of patients and being able to identify who you should be watching. I know real-time system, and I know Innovacer has lots of data and data dashboards and sources more globally for patient management, and in real time they have the same things with very important dashboards that the nursing home and the nursing team can use, and/or folks like us who are helping them manage these specific patients can use to get ahead of those things. So every day you can't focus on your 80 long-term care patients, but you have to take a quick look at each of them because something could have developed over time or each day. And so I think kind of staying on top of that and having a focused effort to do that is clearly going to impact your ability to improve care. I don't know if Katie, if you also were trying to make a comment on any of these here. I'll just open that up in case you did. I know we work directly with with you and your team to do this as efficiently and timely as possible. And maybe you want to comment on that, or it'll come a little bit later in our discussion.
Yeah, I have some comments on that, but I think it comes in 2 or 3 slides, kind of break it down into our care coordination and how we use real time to manage those residents. So I'll pop back in when we get to that slide.
Sounds good.
And so
Hey, I
maybe
think we can
go to the
go
next
ahead,
slide.
Brad. Yeah, that's
I think
exactly what
Phyllis,
I was saying.
both of us were on the same page with that one.
Imagine
And
that.
exactly. And while we're bringing that slide up, we did have an additional question about the impact of readmissions for adult and pediatric populations. Navasar, we do have a number of pediatric pediatric customers, and certainly, it's interesting the performance value care delivery programs are materially different in the pediatric population because a lot of it centers around well care as opposed to sick care. And the incentives and how you can promote more of that. And certainly we do see that there are a lot more chronic conditions and behavioral health issues in the pediatric population. It's fundamentally just I think it's very different than when you're looking at the adult population by and large. And so we certainly do see that in a lot of our clients. Some of our clients, for example, I know that are very active in managing both populations like Banner and Chess. They have very specific programs that they've designed for the different populations to ensure that they're targeting the specific issues.
Okay. And with the slide there, we just wanted to talk a little bit about the dollar impact that we see. And this data comes from the Transition of Care group. It says 44 billion per year are spent on poor transitions of acute care Medicare patients to post-acute facilities. So what does that mean? Is that all readmissions? Well, it certainly is the majority of it, but it's redundant testing and without the great interoperability that we've talked about, having the right data at the right time to manage the population and those poor transitions of care, whether it's medication. It's really funny. I learned this when my dad went through some hospital stays and ended up in acute care. And at home, he was prescribed one statin, right? When he went to the hospital, he got a different statin because that's what their pharmacy kept and that's what they did. And then when he got to the post-acute, he had a different statin. And when he got home, he had all three of them. And it was very confusing to him as to which one he should take and why. And he'd say, my regular doctor said to take this one, but now they're telling me to take this one. And so it's not only the readmissions, although that is certainly a dramatic part of it. It is the med reconciliation. It is making sure we're treating with the right antibiotic based on, what we have in the community. And so, Keith, I'd be interested in hearing, what you've experienced from a dollar impact on those types of transition issues.
Yeah, they make or break value-based care programs. And the ISNP, which is a Medicare Advantage plan for institutional long-term care patients. There's this slide is clearly interpreted and understood by CMS and HHS because it's why they have been concentrating on additional and maybe even crafting more value-based care programs. They're talking a lot these days about fraud and abuse and stopping that and saving the money. They're talking about poor transitions in this particular arena of acute care to post-acute. But what they're really trying to do is save the Medicare Trust Fund. And every day, every week that goes by, that becomes a little more critical and no one has that answer. But I think if you step back and say, well, what could we do today to make the system more efficient in the spheres that we live in? I think the outcome of that can be hugely impactful. So while it definitely impacts the impact to the nursing home operator, the hospital operator, the PCPs. Ultimately, it's going to impact the ability of the program to provide the funding to care for as many millions of Americans that it does today. So it's not going to go away. It's going to be something. It's why we're here today, to talk about what we can do to make a difference in the worlds that we touch.
Okay, and if we can go to the next slide. So obviously you guys know that I'm from real-time medical system, and some of the barriers that we talked about, that interoperability, that risk scoring, providing the right care at the right time. That's what real-time does within the post-acute system. And real-time and Innovaccer have developed a dynamic partnership to link that post-acute data at the patient granular level that Keith has been talking about, to be able to use that through the Innovaccer platform and to really help manage that kind of black box that most people have in that post-acute setting. So looking at those subtle changes in conditions, risk stratifying those patients, and then providing standards of care on what to do when. So just wanted to introduce that, make sure everybody understood there's a great partnership between Real-Time Medical and Innovaccer around managing these post-acute patients. And so we can move on to the next slide.
And while we're waiting for that next slide to come up, please continue to put comments, questions in the chat. We really appreciate the participation.
Yeah, and I think this slide, Keith, I think this is really you and Katie talking about what you've experienced from partnering with real-time and care coordination and managing those patients in that ACO REACH and iSNP program. So if you would kind of talk a little bit about what that partnership looks like, how it works, and what types of results you're seeing.
Yeah, I'll go ahead and get us started, because this is the part this was the slide I was waiting for. So we are able to use real time, right? And you can see our online portal over to the side to get a glimpse into that facility's EMR. And we can look at each resident individually as well as the whole facility overall. We are able to do some daily clinical monitoring, again, per patient or whole facility. We are lucky enough that not only can we see down to the nitty gritty, we can pull back and see any opportunities around hospital admission trends, right? Because not only are we looking at one facility, we're looking at all the facilities together. Is this a process issue? Is this everyone has UTIs? Is this an opportunity where we can step in, provide extra support, provide education or anything like that, so that we can stop those hospital admissions and readmissions? The other thing we do, and everyone's going to think about a patient that they know when I say multi-visit residents, those residents that are going back to the hospital several times, including several times in a month, right? Every time you turn around, they're going to the hospital, they're coming back. We're able to identify those residents and look at, why are they going back? What's the common theme? What can we do to stop that? Have those conversations with provider partners and their clinicians, so we can hopefully stop that carousel of that resident going back and forth, and provide that better care for not only that resident, but everyone that's taking care of that resident.
Yeah, I mean, so for us as a organization that is a value-based care program administrator, if you will, as I said before, we're clearly partnering with PCPs in long-term care and the facility in long-term care, and the key people that work in those buildings that provide clinical care. And so by using the real-time system, it's actually enabling us to manage patient populations effectively in a value-based care environment. Without this type of actionable data, we would just be effectively taking risk without necessarily adding care management resources. in this scenario, we're doing two things. We're providing the analytics and utilizing the data that exists in the facility MR, but then more importantly, translating it into having an expert like Katie or a member of her team take that data, interpret it, and get ahead of those things that what we often refer to as interventional moments or alerts. And then we talk to our partners. And that can be the DON in the nursing facility. It can be the PCP provider for that patient. It can be both. Having that three-legged stool work very collaboratively gives us the best outcome, because then everybody knows what's going on. If we identify something from the data, we're not going into their medical record and documenting. We're not basically telling people what to do. We're making suggestions on what we think based on our historical performance and our years of doing this, of those things that need to be addressed. It's often there are times where those alerts are because the patient still has the issue, they're aware of it, they're treating it, but it's not showing that it's made an impact yet into the data that we have through real time. So my point with saying that is there can be false alerts, but by having a real expert that knows how to use the system, along with however the building decides to use the system to manage their total patient population, the reality is it makes a huge difference, because then you're viewed from the PCP provider or the DON as an extra tool in their toolbox they never had before. Our programs are meant to partner and be efficient, not to add more work to somebody's already very, very busy day, whether you're talking about that PCP or that DON. They don't need one more thing to do. They like to know when there's one more thing they should do.
Exactly. We like to refer to ourselves as that second set of eyes. We have, the luxury of being able to take all the pieces and put them together and think about the whole clinical picture versus the front line who is answering call bells and physically taking care of these residents. So we get the time to put the things all together and present it to them with some back thought already put in it for the facility. And if we go to the next slide, I can just touch on a little more about that clinical monitoring, how we're reducing those readmissions and admissions. And our biggest thing is identifying those subtle signs of clinical decline, right? Identifying, like you said, those opportunities for intervention at the facility before someone gets so sick they have to go to the hospital. And we can do that using our platform because we pick up on things like when someone stops eating as much, right? When people stop eating, that means they're sick or dying. And it's usually 3 to 4 days before they get a fever or any other symptoms come up. We can see a slight drop in their blood pressure, an increase in their pulse. So we can intervene there, right? That says, hey, they're not at their normal, something's wrong. And we can kind of pull the trigger to take a second look at this resident. Hey, can you go talk to them? I had a patient just yesterday that I sent, hey, their heart rate's up and they're not eating as much. The provider went and talked to them. Turns out they had a giant UTI that they were brewing, no fever yet, nothing big, scary happening yet. They were able to start those antibiotics. They were able to give them some symptom control and send off their labs all before that patient got super symptomatic and had to go back to the hospital. We also look at those high-risk residents, right? We risk stratify every one of our residents every 24 hours so that we can provide a blueprint or roadmap to our providers. Like, hey, here are your 5 sickest, highest risk residents. Maybe you want to see them first, or maybe you want to increase your rounds on them. And instead of seeing them once a month, see them, twice a month. Kind of get those extra eyes, extra hands, extra assessments in on that. We also, like I said, we look at those root causes of readmission, right? We're really big on doing order reconciliation. That transition of care is a huge vulnerable time. And so we can use this data we're pulling over. Are they getting the medications that they were prescribed? Are they, finishing their course of antibiotics? Are they on the right antibiotic, right? Is their culture back and the antibiotics wrong, so they're not getting any better? So we can use all this data that is flowing from the EMR to our portal to see that. And it's not any extra work for the facility. It's not any extra work for anyone except for us saying, hey, go take a look at that patient I don't think, their antibiotics correct. And then they can go assess that patient and make that decision. The last thing we do is use our data to appropriately manage length of stay for our Med-A residents, right? We are not out to have short stays, we're out to have appropriate stays. So if someone who is low risk, right, and they've been here for a long time with a appropriate diagnosis, we can start talking about, hey, they've been here, on their Med-A stay for 30 days. They're here for a hip replacement. They seem to be functioning at, their baseline. Let's talk about them going home or them transitioning to long-term care. And we can manage that stay so that they can get back to either their community or their lives at the facility, and get back in business to what they like to do. Right? That's what it's all about, taking care of these patients, what you would want to do for your grandparents or parents, and giving them the best care possible.
Yeah, and just to add, one of the things we hear from our partners in the value-based care programs is that this is truly a new partnership that they have that's identifying those subtle things that Katie talked about, that happen very frequently with long-term care patients that otherwise are missed, not because somebody's not good at their job, simply because they have a lot to do, they have a lot of patients to care for, and there's only so many hours in the day. So we're trying to get ahead of that to continue to improve care and timely care. The timeliness of care becomes critical to avoid all the negative things that can happen to a patient.
Absolutely. And and there's a couple other questions that are coming in, and so certainly please continue to have them come in. We'll answer some more questions, and then we have one more audience poll for you as well. And so one question was in terms of some of the graphics. I wanted to know where these they're an Innovacer client and they like the colors in the graphics. If you like the colors in the graphics, we can absolutely talk to your client delivery team and we can get whatever colors you'd like. We generally have a standard palette that we use, but certainly are open to using whatever colors that you'd like. They have another question that came in. That is, most of our SNFs are on PCC. I think PCC has something similar for ACOs. What's different about this program?
Yeah, I can take that to start. So the difference is we link to PCC, but we also link to all of the other EMRs that are out there. So you're not limited by EMR. The other thing we do is we bring all the data in, standardize it, normalize it, and you don't even know what EMR you're in. You're able to see the data presented the same way across your entire network. So it really makes that interoperability piece flow very well. We're able to get the same data out of each EMR that we work with, and present that back to you. So you don't have to worry about logging into one EHR or another EHR. The platform is EHR agnostic, and that makes it really easy for your network to use. By the way, usually the network, if you're in a SNF network from an ACO or value-based care program, the SNFs actually get to use the tool as well. And so the tool is designed not only for ACOs and value-based care, but to help the SNF with their daily clinical work. If you've tried to go through EMRs to find data, whether it's a SNF or a hospital EMR, it oftentimes is difficult to get to where you want to see the data at, and it doesn't raise the level of looking across your network. That's something that we do, and certainly have had a lot of networks help us build the right types of tools on the data they want to see, and the data is customizable in terms of what you're seeing. So I think we'll go ahead and go to the next question, which I think is a poll question. I'll turn it back to Dr. Silverstein.
Yes, absolutely. And so this is our last poll question. And so we're going to be super excited to see what your results are, and we'll discuss those. And then, of course, feel free, keep the questions and comments coming. We really makes it more interesting for us and hopefully for you too. So our last question is, where does your organization really stand today in the battle to reduce 30-day readmissions? And you're going to have four choices for this one as we're bringing that question up. It should be popping up momentarily, all through the wonderful power of technology. And so giving you a preview for some of those as hopefully this is going to pop up soon. One option is that you just started an exploring option. The second option is pilot efforts are underway. The third is processes in place showing some results. And the fourth one is processes in place and you've achieved some results. And so that question should be popping up soon. I think we're working on getting that thing to fire. And while we're working on that one question to fire, then certainly Phyllis, Keith, any guesses as to how this one is going to turn out?
I
Well,
would
my
say,
hope is that, oh, go ahead, Phyllis.
no, it's fine, Keith. You go ahead first.
Well, no, I was just going to say that, my guess is at this point, process is in place showing some results because it's clearly on people's mind. But I also know that there are going to be people that fall into the just started exploring options or maybe are piloting. It's tough to pilot these programs without really doing them well because you're not going to know what the real outcome is. However, you can pilot, say, do a program like ours in a handful of your buildings and see how that goes before you launch to all your buildings. That gives some folks comfort and flexibility that they're not jumping fully in. They know that it'll work. It'll be a process that's helpful to their patients and their folks that work in their facilities, and is well received by the PCPs as an additional support item or tool in the toolbox, which is that old saying that sometimes gets overused. So I guess I wouldn't be surprised if there was lots of answers in all four of these.
Yeah, I think you're right. We certainly know this is an issue and it's not new. It's been going on for a while, ever since value-based care really came into the market in the, 2015, 13 to 17 range with MSSPs. And so I think there have been many approaches out there. And so I would be surprised if most people haven't started something already, but yet we still continue to struggle with the results. And so obviously with the people here today, this is something that's interested you. And so I think we still have a ways to go on this. So agreed. I think the results will be scattered.
Well, we're going to have to just guess because the poll hasn't launched yet. And so maybe it will launch soon and then we'll be able to actually know for real what the results are. But until then I think that it'll be a little bit of a mystery for us, but nonetheless, I agree with the commentary on it is that, this is certainly something that everyone understands it and is focused on it and has certain levels of effort. And like many situations, there's so many different competing priorities for resources, time, and attention. And so part of this is just when does this become a big enough issue that it makes sense to make the investments on the resources? Because like many things, this can be solved. This isn't something that isn't solvable. It's about, do we want to invest in the systems? Do we want to invest in the people? And when you make those investments in the systems and the people, and some of the earlier questions, hey, how do you manage the TCMs? There are known things you can do when a patient is in one care setting that's going to be transitioning to check in with them, monitor them, that will absolutely make a difference. It just becomes a question of how do we systematize the things to do and do it at a accuracy and cost basis that makes sense.
Yeah, and Brian, I'd say that if you think through the last almost 55 minutes we've been together, that our discussions have really focused on care delivery, and people. And those are the key ingredients to managing any type of patient and doing it well. And that takes a lot of work because it's a process that can be standardized for the most part, but every patient is unique, as you all know, in the audience. Taking care of these patients in many ways can be very, very different and unique, except the same things happen. And that's what makes it very similar. And so, but I think if you ended up answering any of the four options, while we've concentrated on the people, the process, and the care delivery as the key ingredients, what we didn't discuss too much about, although we did in our $44 billion schedule, was that it's probably time for you to start investigating and considering your value-based care options because A, it's pretty clear the government's pushing Medicare beneficiaries across the country into a program. In the last administration, it was very much directed that that happened by 2030. Well, it's 2025, so that's a lot of people to get into value-based care or managed care in healthcare that are Medicare beneficiaries by 2030. I don't think they're not going to keep pushing that goal, even though it's not as explicit with the new administration. They're just more focused on people need to be in care, value-based care programs to get the better management. So having said all that, what I'd say is if you, regardless of what your answer is, you should consider learning and joining a value-based care program because then what it does is it untaps the value of the dollar. So if you do all this really good stuff and you have everything in place, you're creating savings to the government. That's fantastic. They love that. But you should get your share. And that's what our organization and organizations like ours does, which is to figure out how to incent and share so everyone gets the benefit. And then, of course, that helps run your business, whether you're the PCP or the facility. And so I think we finally have the poll up here, and hopefully people are starting to vote.
And Keith, fully agree with what you're saying there in terms of the ability to have the right focus and identification of, hey, it makes these things, it's how do you fund the infrastructure and really make sure that you're having that conversation. And especially for some of these teams, it might be that, we need to have a skilled nurse that's available for this because you know why the patients are that complex. And that's really where you're going to get the impact. And it's about it's saving Medicare money, but it's also then ensuring that there's fund flow for continued investment in this. And so the poll is up, as Keith indicated. And so certainly we want to hear your results. Let's see if our predictions were correct, if they are going to be scattered or not. We'll take a look at the results. And then after that, we'll give everyone a chance to give their parting thought. And then we'll conclude our webinar. So the results they're in. And as predicted, it is scattered, although there are a couple that are more predominant. And so the number one is processes in place, showing some results. Number two is going to be just started exploring options. We've got number three, pilot efforts underway. And number four, the wording on its process in place, results awaited. And so I think results not there yet, but so nonetheless, it is scattered as predicted. So I think we got that one right. So we've got a couple moments left, and certainly want to give everyone a chance to give kind of their last word. And Keith, go to you, and then Phyllis, and then Katie, and then we'll close us out.
Sure. Thank you, Brian. I think the main thing is whoever becomes your value-based care partner, start to learn about value-based care programs if you aren't already, and how it can improve the care of your patients, and ultimately provide the financial incentives that help you make the reinvestments in more preventative care. So don't think you're behind. Just it's time to start to investigate and learn.
Yeah, I would agree with Keith. Value-based care is here to stay, whatever form it takes, whether it's MSSP, iSNPs, ACO REACH, the TEAMS model I mentioned briefly is out there. So everybody has to move in that direction. The best way to get the best outcomes is to partner across the continuum and share that data so you can do the right intervention at the right time, in the right place for the right patient. So making sure you have that data, can use it, and partnering across the continuum, I think, is really important for that value-based care.
Yeah, and how nice is it that value-based care rewards you for doing what's right and best for the patient? I think that's the most important thing as a healthcare provider that we strive to do. And so I'm really glad that that's the direction that everything is going. And just like Phyllis said, connecting across the continuum so you get the full picture is very important.
And I want to really thank Katie, Phyllis, and Keith for joining today, and all of you that are listened, for all the great questions and comments. And this really is something that can make a big difference in financially, but also in patients' lives. And so we're going to continue to advocate for the things that will, make the processes better. So with that, really appreciate everyone's participation, and looking forward to continuing the conversation.
Great. Thank you all.
Thank you.